So now we move on to the another prestigious Dr. Pushpa Banerjee Oration by none other than Dr. Prakash K. Mehta. I request our distinguished chairperson, Dr. Radha Jeena ma'am. She is ex-professor BRD Medical College, Gorakhpur, patron Gorakhpur Autism Gyne Society, and past president of UP chapter of Autism Gyne. Dr. Anita Chandra ma'am. She is the director PC Chandra Medical Center, executive member GOGs. Dr. Anubha Gupta, Vice President, Gorakhpur Autism Gyne Society, Director at Vardhani Hospital, Gorakhpur. And last but not least, Dr. Shikha Seth ma'am. She is a professor and head of the department OBGY AIMS Gorakhpur. She is the scientific secretary of Gorakhpur Autism Gyne Society.
Good morning again. It's again time to introduce another legendary in the field of Autism Gyne. She is none other than Dr. Pushpa Banerjee. Dr. Pushpa Banerjee was born on 21st March 1930. She graduated from SN Medical College, Agra in 1953 and she did her DCH from same college in 1955. She joined Provincial Medical Services and was posted at various places like Meerut, Ghaziabad, Allahabad, Moradabad, and her last posting was at Gorakhpur, where she served as Senior Superintendent of Dufferin Hospital, that is female hospital, from 1979 to 1988. She was the first woman doctor to be posted as Deputy CMO Family Planning and Health, and later she was CMO and Joint Director Medical and Health Services, UP Government. She was also instructor for sterilization and MTP training, and she was a very dynamic lady and a great administrator who changed the face of Dufferin Hospital. She was a strict disciplinarian at work but very supportive for her subordinates. She was a fearless administrator who could tackle any situation, and she never entertained any politician for this purpose. She was the one who initiated and worked hard to start Gorakhpur Autism Gyne Society, and with her effort it was started in 1988. Though she is not with us today, but she will be always in our life and we will always remember her. Today Dr. Prakash Mehta will be delivering her oration. The topic of the oration is Solution to Changes of Preterm Birth in India.
Good morning everybody. Now I welcome Dr. Prakash K. Mehta. He is Chief Division of Maternal Fetal Medicine and Head of the Department of Obs and Gyne, Bhagwan Mahavir Jain Hospital, Bengaluru. He is postgraduate and post-PG fellowship teacher and examiner in maternal fetal medicine and Obs and Gyne. He has published numerous articles in various journals and chapters in books. He is editor of international publication Hypertension and Enigma Unrevealed. He has delivered oration in field of maternal fetal. He is President Society for Maternal Fetal Medicine India. He is past President Bangalore Society of Obstetrics and Gynecology. He is past Joint Secretary FOGSI. He is best teacher. He received Best Teacher Award from NB Institution 2019 and Bangalore Society of Obs and Gyne 2020. He has his training and upskilling in Ops Emergencies G20 and Government of Mizoram projects. He has received Lifetime Achievement Award from Karnataka State of Obs Gyne Association. I welcome you, sir. Please start.
Good morning, everybody. I feel indeed honored to be giving an oration for such a great personality. What struck me was one of the introduction given that she could tackle any situation. That's what applies to the critical care. We should be ready to tackle any situation at any time if we are going to handle a critical care patient. And I should also say that I owe this oration to all my fellow gynecologists across South India and Maharashtra who have been referring their high-risk patients to me, allowing me to get a great experience in this field, as well as the patients from whom I have learned, because every patient is different. Every patient behaves differently when you try to treat them. All eclampsias are not same. All health syndromes are not same. And the patients have taught me a lot, and I'll be ever grateful to them for that. Next. When we are doing critical care, I think this quote is a must. Om Gajananam Bhuta Ganadi Sevitam Kapita Jambu Falacharu Bhakshanam Umasutam Shoka Vinasha Karakam Namami Vigneshwara Pada Pankajam. You need somebody behind you who is always there with you to protect your patient. Let me tell you, there are many times when I have told the relatives, I don't think your patient is going to be alive tomorrow morning. Or when my fellows call me, I said, no, I don't think this patient is going to make it. And next day morning you go and lo and behold, the patient is very stable. And opposite also has happened. There are times when I tell the patient, oh, don't worry, I think she's settling down now. And the same night she expires. So that's why you need some supernatural support for whatever you are doing. Now, pregnancy can be the most wonderful experience life has to offer, but it can also be the most dangerous. And basically, when we talk of a high-risk pregnancy especially, then we go through a turmoil, then a turbulence, and then finally a transition for good or for bad. Long back, this was in 1834, James Bundell, I hope you remember who James Bundell is from the history you learned during your postgraduate days. He was the first one to start off blood transfusion, even before the Landsteiner's blood group had come into being. And what he said? He said that it's clear that when patients are in this condition, trembling upon the very brink of destruction, there is but a little time for you to think what ought to be done. These are the moments in which it becomes your duty not to reflect but to act. Don't think too much, just act, because that particular time what you do will save the patient or no. Maternal critical care is a developing area of clinical practice. Still, we don't have very many maternal fetal medicine specialists who are really doing the critical care. In the USA, it's for quite some time that obstetric critical care is a subspecialty, I should say. After you complete your post-graduation in OBGYN, then you do your maternal fetal medicine, and then you can go further down to the maternal critical care. We are still one level behind because as a maternal fetal medicine person, I have to handle the critical care cases. Of course, it requires a multidisciplinary team. It is not that you can do everything single-handedly. No, multiple systems are involved. Multidisciplinary care is required. But what is more important to remember is that the unfounded concerns for the fetus. Chest X-ray? No. The baby will get radiation exposure. You must remember that the radiation exposure, at least 1,000 X-rays minimum have to be done before that fetus can be affected. Okay, so don't allow these concerns to cause a therapeutic inertia. We should be bold enough at that time. You are choosing between the devil and the deep sea. Either way you are going to sink. So try to do something which would save the patient. And many life-saving therapies are denied to the pregnant woman. One of the very simple example would be a beta blocker. I've seen any number of patients not being given beta blockers because, it can cause FGR. How many beta blockers you are giving, at what stage of pregnancy you are giving, that also becomes important. Today, if she has got a mitral stenosis or she has got a cardiomyopathy, beta blocker is the drug of choice. So don't hesitate, give it. And another very important thing, we always think, critical care patient is not going to die on me. It can happen to someone else, not for me. But that's where we are wrong. Never say that it won't happen to me. Life has a funny way of proving us wrong. You carry umbrella every day, it doesn't rain, and one day you go without an umbrella, that's the day it's going to rain. So 1 to 3% of obstetrical critical care patients only require critical care. Only 3% of all your obstetric patients would require a critical care. But any insufficiency in the management of these patients could result in a morbidity or mortality. Okay, so we have to be very careful about them, and what is also more important is that we are a little fortunate that most of our complications requiring critical care come in the postpartum period. Because if they would come in the antepartum period, then I have to rack my brains even more, because you have to decide for the baby, for the fetus, a lot of issues start coming in. And we today do not have a fetal-friendly environment in the intensive care units. So what we really require are the pure obstetric intensive care units, so that even in the fetal-friendly, I have delivered many cases in my ICU. Let me tell you, those are the times when I'm really, really scared. Because your labor room nurses know what to do, what to give, when to give, how to give. You get a good lithotomy position. Here the patient is on a ventilator, or the patient has got thrombosis throughout her body and you're not able to flex her legs, and you try to bend across, the blood doesn't break. You try to bend across and try to get the fetus out, and also trying to ensure that this fetus survives. It's a very, very difficult situation. So that is why now once the concept of the high dependency unit came in, I was one of the first to have a high dependency unit in my hospital, and the high dependency unit is really helpful in the sense that unless a patient requires a ventilatory care or a dialysis, now even dialysis seems to be out because I do dialysis in my HDU also. But ventilatory care, yes, still it requires the main ICU. But rest of the things we can definitely manage in our high dependency unit. Unfortunately, the obstetric critical care in India is lagging much behind. It's possibly because we have been so carried away with trying to save women from anemia and things like that, I again distinctly remember a meeting of all the vice chancellors we had in Mumbai a few years back. And when we started talking about the high dependency unit and how every medical college should have a high dependency unit, they said, come on, there, patients are dying because of anemia. Let's give them iron tablets and save them instead of you're talking of such high things. Now today we realize that like Madam said, change is life. So even here the change is life. You have to, once upon a time, yes, iron deficiency was the most important thing that we ever had. But today we have definitely not 100%, but we have already crossed the 50% mark in trying to bring down our anemias. So next we have to tackle this 3%. Okay, and we need a provision of separate ICU services for the critically ill obstetric patients, and early assessment and aggressive intervention is more important. We need to be aggressive, we have to be aggressive, we have no choice. Okay, and many maternal deaths or near misses are associated with substandard care. I'm sure all of you who are doing a maternal mortality audit will agree with me that when you go back to the case sheet, you will find that something could have been done much better for this particular patient. Now, which patients go to ICU? There were a whole lot of obstetric and non-obstetric indications. I'm not going to go into too much of detail of it. But when a patient requires critical care, there are 5 most important. One is the hemodynamic instability. Second, the respiratory dysfunction. Third, the neurological complications that come in these patients. Acute kidney injuries are very common in our field. And finally, the hematological complications that come in. So we have to be ready to tackle all these complications. So when you are doing critical care, the same thing happens. What you least expect to not trouble you troubles you the most. Okay, so I have been fortunate that I have seen patients when I was a postgraduate, of course not as a consultant, but seen the patients coming in a bullock cart. To that, I reached the stage today when my patients are transferred across to me in a helicopter. So there are all kinds of transports are still available in India. There are many areas, especially the hilly areas, and I was told in Nepal most of the pregnant women who need very high risk care are transferred on a donkey because nothing else goes onto those mountains. So those kind of things are happening. But what is important to remember is that an adequate skilled team must go with the patient and an appropriate equipment should be available. Not every one of us can afford to have a critical care set up in our hospital. So the best thing is to do is to have a understanding with a nearby hospital who has got critical care, and when you are transferring a patient, better than one of the senior persons go. Maybe if you are very busy, one of your senior nurses or your anesthetist could go. Later on I'll show you a case which I could save. It was a case of amniotic fluid embolism. I could save it because when anesthetist came continuously through a transfer of 6 hours, bagging her on the way. So that's how the patient was saved. Okay, so this kind of, you must have that much. I think I've seen patients being referred to me without, not even in an ambulance, a shock patient being put into a taxi or an auto and sent across to me. And then if this patient sue, we say, oh, medical legal atmosphere has become very bad. You know, somebody should have gone with them, put them in the proper ambulance, put proper oxygen, have some proper drip on flow. But somehow, you know, we seem to be missing out a little bit on that. Just a few cases quickly we'll go through. This is a 29-year-old low-risk primary gravida. She was referred to me with severe PPH following an inversion of uterus. Now look what happened to her. She was admitted for induction of labor at term. She was induced with Saviprime gel. Patient had vaginal delivery with RMLE of a live male baby of 2.8 kg after 24 hours. Now by the time the 24 hours were getting over, the obstetrician must have been obviously very tired and didn't have enough patience to wait for the placenta to separate. Not clear?
Use the podium slide that would be still.
Okay, I think this is better. Yeah. So what happened was that they have tried to pull on the placenta. Of course, they hid the fact from me when I asked them what the gynecologist had come with the patient. I said, what happened? No, the placenta came out and after that the uterus just inverted. And that too, it had not come out fully, the placenta. So, post-placental expulsion, inversion of the uterus was noted and followed by a postpartum hemorrhage. Uterus was repositioned, at least that's what they told me, that they repositioned the uterus and they did a packing so that it doesn't come out further. All they had done was that the inversion was sitting there and on the inversion they put a pack and then brought the patient across. They had already transfused 3 units of PRBC and 1 unit of FFP along with 3 units of Hemaxil. I hope all of you would very clearly remember that when you are giving an Hemaxil, if you give PRBC along with it, you know, you are neutralizing whatever benefit you are giving to the patient. Okay, so that should not be done. And then the patient was transferred to my unit. Her general condition was very poor. She was in shock. Peripheral pulses were extremely feeble. 180 beats per watt, the rate they got. The SpO2 was still maintained. She was on Paxil 1 drip, oxytocin 1 drip, and dopamine 1 drip. So with 3 drips, she came to me. What do you think was the biggest mistake that was happening there? Great. Oxytocin was being given to her. So whenever there is an inversion, you don't give oxytocin because you're causing the constriction ring to become more and more firm. BP was 90/60, Foley's catheter was in place but no urine was draining. Uterus was about 14 to 16 weeks after a 2.8 kg baby being delivered, and there was a nice dimpling at the fundus. And there was a pack in situ, and through the pack I could see the bleeding. So first thing we did was to shift the patient to the ICU and ventilate her, arrange the more blood products. The inotropic support was stepped up. What was a single inotrope support, I made it a triple support. But patient had cardiac arrest within half an hour of reaching the hospital. So unfortunately, it takes a little time. We tried, of course, repositioning. I even used a science taken tube and tried to push the uterus in. But since the constriction ring was already formed, the only recourse to me was to do a laparotomy and pull her up uterus. So for that, at least I required some amount of blood before I could take her up. She had cardiac arrest by the time we had put her on the trolley, and she had arrested on the trolley, revived her. Then uterine repositioning was done, but after that she had recurrent episodes of cardiac arrest, and patient could not be revived and had to be declared dead within 2 hours of admission. So these are the cases when you really feel bad that she could have been saved, or she did not have to die. She did not definitely have to die. All that when you waited for 24 hours for an induction to succeed, another few more minutes for placenta to separate by itself. But I have a movie ticket at 6 o'clock. I have to go home. The other case, she was a 29-year-old para 2 living 2, referred for tertiary care post LSCS with eclampsia, health syndrome, acute renal failure and pulmonary edema. And look, you can see the reflexes, how brisk they are in this patient. What happened? It's not going well. Yeah, so she had a bilateral grade 2 nephropathy, minimal GB wall edema. I hope all of you are doing an abdominal scan for your patients with hypertension, because gallbladder wall edema is very easy to pick up, and if you have a hypertension with a gallbladder wall edema, unless you have an intensive care unit with you, please don't keep her with you, because it means she's going in for health syndrome. And health syndrome cannot be managed in smaller setups. The uterus was subevoluted, and of course do we have to marker with this? Okay, doesn't matter. And there was a pulmonary edema, and if you could look into this tube, that's a typical pulmonary edema will look like that. You'll see a pink frothy sputum moving across all over, and in the jar also you can see on the top there is a frothy layer. Of course, she also had a PPH, so we had to do an embolization to stop her bleeding. That picture is of a uterine artery embolization. Then she started, creatinine and potassium levels started rising, so she needed dialysis. And finally, symptomatically she improved 3 days later. The bilirubin decreased, the renal failure, however, persisted. Renal failure doesn't go away immediately. So she, at the end of 2nd week, only the urine output started improving. At the end of 3rd week, she finally had a normal renal function. And the mother, I could discharge her 3 weeks after admission. 23 units of blood and blood products were transfused, and post-discharge creat was 1.5. And you could see the way the urine color has changed over that period of 3 weeks, starting from almost a fully bloody urine, what we call as a cola-colored urine, all the way to a totally clear urine. Another case, she is a 23-year-old primary gravida. This was the patient I was telling you how she was saved, because there was an anesthetist with her in the ambulance. She was a 23-year-old primary, referred in shock as amniotic fluid embolism and DIC. Now, this patient was in Anantapur. Anantapur is Andhra Pradesh, the next state to Karnataka. And to come from Anantapur to Bangalore, it takes roughly 6 hours. So when they called me up, I said, what is the point? 6 hours, she is not going to survive. Their answer was very simple. Sir, she is going to die anyway. We may as well take a chance that you may be able to save her. So she was transferred 6 hours across a journey with ventilation going on. And her history was also very little funny, in the sense that an augmentation of labor was done with oxytocin at 11:40 a.m. and she received injection Drotin and Epidocin. I don't know how many of you are still using Drotin. Anybody still using Drotin here? Okay, good, because I've seen it being still used in Bangalore. Yeah, Brotin, if you remember, is contraindicated in labor. The government of India has come out with a regulation saying that you cannot use. What you are doing is out of package use. And when you do out of package use, you are very, very liable in the court. Okay. And patient had 2 episodes of vomiting followed by which the patient developed the swelling of the whole body and the face. So there was a slight doubt that whether an allergic reaction had come in. Pulse was feeble, tachycardia had come in, BP was not recordable. So in that particular hospital in Anantapur, they gave her a multidisciplinary care, anti-shock treatment, steroids, inotropes, everything was given. Patient was stabilized. By that time, she had an intrauterine fetal death. Now, since there was an intrauterine fetal death, they decided to continue with the augmentation. They said, we are not going to do a cesarean section, we are going to try for a normal labor. And they tried for a normal labor, and finally a forceps-assisted vaginal delivery was conducted, and a male stillborn baby of 3.5 kg was delivered. Patient had 1 episode of vomiting followed by unconsciousness after half an hour, and later the uterus was relaxed with bouts of fresh bleeding. Now, you know, amniotic fluid embolism is a very, very funny situation. It can come to you as dyspnea, or it could come as a DIC presenting for the first time without any respiratory symptoms, without any drop, or rather a very significant drop in a saturation. So if you see a DIC in a patient post-delivery, please keep in mind that have I missed out an amniotic fluid embolism or no? The patient's condition had then deteriorated, transfusion and inotropes were started. Her hemoglobin was now only 4 grams per cent with an unrecordable BP and feeble pulse. So that was the situation in which she was transferred. That's to show the height of a uterus, because the uterus by that time had started relaxing. That's the patient on ventilator, and finally with all efforts the patient settled down, and that's the husband and the patient. She came to me after that 2 more times for delivery. After 2 times I said, I'm going to do tubectomy. No chance further. This was a 20-year-old primary gravida, regular antenatal cases with a history of pain, abdomen and vomiting. Her blood pressure was 180 by 140 and the urine albumin was 4 plus at 30 weeks. Her HB was okay, 9 grams, a little bit anemic but not too bad. Her PCV was 40.5%. How many of you do really PCV or hematocrit for your patients? Great. I'm very happy, because doing only hemoglobin percent is not going to give you any value whatsoever. What you have in preeclampsia is the hemo concentration. And if you have to see hemo concentration, you need to do a hematocrit. And also remember, in pregnancy there is a hemodilution. So the hematocrit values will not be more than 30%. Most of the time you will see it is between 28 and 30%. So you see a hematocrit of 35, 36, 38. I've seen patients with massive PPH with a hematocrit of 45, 50% and an hemoglobin showing me 9 grams. You know that it doesn't have any value at all. That HB of 9 grams doesn't carry any value. Because if I were to bring down the hematocrit to 30%, her hemoglobin would be about 5 or 4.5. So she was stabilized, magnesium sulfate given, live male baby of 980 grams was delivered, PPH was there of course, controlled. Post-delivery, 1 hour later, she has convulsions, she had distension of abdomen, she had hematuria, the hemoglobin dropped again to 6 grams per cent, and she developed pulmonary edema, had to be put on a mechanical ventilation. Now, patient soon started becoming drowsy with decreased motor power in the right upper and lower limbs. So, did an MRI, and MRI very clearly shows, you can see this, much more whiter compared to the rest of the brain matter, showing that there was an occipital lobe localized edema, and the diagnosis of Press was confirmed. Now, Press is one of the good diagnoses to have on your patient because it can be reversed. At the same time, we should know she could have possibility have other causes for convulsion with similar history, and these are some of my other patients who had this kind of history. It could be due to intraventricular and a cortical bleed. It could be due to, if she has come a little later, maybe 48 hours later or something, cortical vein thrombosis, or cysticercosis. Cysticercosis keeps on coming now and then. Okay, even I've seen this happening in vegetarian patients also, because cysticercosis is no tapeworm, is got by eating pork. But in the vegetarian, what happens, unfortunately, all our kothmir and pudina and all those kind of things are grown with green water. And the cysticercosis egg and the larva stick onto that. And we on our masala puri and bale, you like to put the kothmir on the top, which is uncooked. Okay. And the smaller the shop you buy your bale from, the tastier it is. Right? So that's how the cysticercosis larva gets into the human being, and it would go into the brain and cause convulsions. Or very rarely, brain tumors. Now brain tumors are occurring at younger and younger age. As a matter of fact, I just saw a patient last week, a 30-year-old girl having a glioblastoma multiforme. You know, glioblastoma multiforme is 6 months life. That's it. Whatever you do. So this patient was a little fortunate that she had a meningioma. We could operate on that, and once the meningioma came out, things were okay. This was another patient, gravida 2, para 1, living 0, dead 1. Previous LSCS was done at 34 weeks of pregnancy. In the first pregnancy, she had an IUD at 7th month with preeclampsia and oligomneos, and it was in transverse lie. So the previous doctor had done a cesarean section for her. And later on, she developed a swelling of the right lower limb, and a right lower limb BVT was identified, and she was put on injection LMW at 60 mg CBD. I hope we give 40 milligram heparin if it is prophylactic. If you are giving it as a therapeutic dose, it has to be 60 BD minimum for a patient who weighs around 50 to 60 kgs. Unfortunately, now a lot of our patients are 80 kgs, 90 kgs, 100 kgs and so on. If they are of that weight, you need to increase your heparin dose even more. But this patient was not very fat, and she was on 60 milligram BD dosage, and finally about 24 hours before surgery, we have to stop heparin. If you are giving prophylactic dose, you stop heparin 12 hours before the surgery. If you are giving therapeutic dose, minimum of 24 hours is required. Okay, this was a patient. I'll just look the whole picture around, then I'll tell you. Outside, and she had undergone a Behling suture. Post Behling suture, she came with severe sepsis, and the MRI, if you could have seen the picture there, it showed that there was a gas in the uterine cavity. So initially I suspected she is having Clostridium belchii, but the culture of course showed only Klebsiella. And finally we had to open her and do a hysterectomy. Post hysterectomy she was fine. You could see the Behling suture marks there. Even when the hysterectomy specimen is over, you will see it better. Because infection is one of the things you have to keep in mind when you are doing a Behling suture. The second complication that I have seen is that as the uterus involutes, the Behling suture becomes a little loose and the bowel can get caught into it. So I have seen intestinal obstruction with that. So that's the uterus brought out with you can see the Behling suture cutting through there. So that was one more case, and then this was a very, very interesting and very rare case. So, although I know I was running a little late, I thought I should include it. It's a case of an abdominal aortic aneurysm with pregnancy. So, patient's pregnancy went on eventlessly, and then we had to deliver her by a cesarean section because she had a huge abdominal aortic aneurysm. So, obviously, I couldn't give her a vaginal delivery. So that was a little worrying because I couldn't even give generally, I'm sure, although it is not really advised, you are the anesthetist to push the baby out. In this case, if they push the baby out, the aneurysm would have ruptured. So I just put in a vectis and got the baby out. My assistant that usually was a young registrar of mine, a very, very dynamic girl. Unfortunately, she had an accident on the Bangalore roads. One truck rammed into a two-wheeler. She fell down and she had a transection of the cervical cord and she became paralyzed from head downwards. So now you will see that behind, you will see the pulsating aorta. Yeah, I don't know how clear it is from there, but you can see that huge sac-like structure is the aorta, which is the aneurysm of aorta and it is pulsating. Now very easy for it to rupture at any time. Even to put that mop, I was really scared because somebody presses the other. I said, no one can put the mop, only I'll put. So this is the angiogram showing the dilated aorta, and this is the MRI picture. Again, you can see the whole of the thoracic aorta downwards to the abdominal aorta, everything is dilated. So finally, this is the mother and the baby. Ultimately, she'll breathe a plasty of the aorta once she recovers from the delivery. So basically, when you have critical cases, please let me know when I have to stop, so that then I'll stop. History and examination. And in the examination, you have laboratory and imaging. And when you do examination, you have to do from head to toe examination. No going shortcuts. Okay, you definitely look for pallor and things like that. Now, investigations, we have got 3 types of investigations that we do for critical care cases. Number 1 is for monitoring. Number 2 is for prognosis and including the point of care test. I'm sure you have all heard that POC. POC is the in thing today for anything in intensive care or even for anything in the labor room, the point of care test, so that I get my result immediately. What happens with us is most of these patients who are sick come on Saturday night. And at Saturday night, who are the people working? Only OBGYNs. Everyone else nicely sleeping at home. You send the report to the lab, you get it all by Monday late afternoon. Okay, there's no point because by Monday either my patient is absolutely normal or she's dead and gone. So that is why the point of care tests have become very important, and we have all kinds of point of care tests now. And what we need to remember that in the pregnancy, the lab values change. Starting from creatinine to LDH to alkaline phosphatase to uric acid, every value changes. So don't look at the lab report, because the lab report, unfortunately, again, women in pregnancy have always taken a backbench, be it society, be it research. So guidelines are only for non-pregnant people. Your lab gives you a printout of so-called normal only for non-pregnant people. So you have to modify it and then try to interpret it. And also remember that lactic acid is a very, very important test that we do in critical care, and the lactic acid values gives a good clue about prognosis. Another important thing that we need to remember is trending. Just like I do once a test, it is not enough. There are times when I have to repeat it every 6 hours or every 12 hours or every 24 hours. So the trending is very important. And this picture I put in because I just couldn't resist from putting this picture. She came to me with a severe distension of the abdomen and preeclampsia. But what the fluid coming out is not hydramnios, but it is ascites. Ultimately, I got 3 liters of ascites out from her tummy, and later on the patient did well. We have various scoring systems. I'm sure MEOS you all know by now. I hope most of you are following MEOS score in your practice, because that is one of the simple things that you could do to save the patient by identifying whether they are going sick or not. And once they come to the for critical care, then Q SOFA becomes important. We have a modified Q SOFA for obstetric patients, and we could use that and do a quick assessment of the patient and arrive at the prognosis. Now ABG is very, very important. Somehow
You can make it short, sir.
yes, that's very important, but somehow we don't follow the ABG. Unfortunately, our residents are not still being trained. In my hospital, I train all my residents in ABG because that's something we should really know. It's very simple. All you need to answer is a few questions, whether it's acidemia, alkalemia, whether it's a metabolic acidosis or respiratory acidosis. It's not rocket science. When you can deliver baby, you're ready to do all this is very simple for you. Hemodynamic monitoring, once upon a time the central venous pressure catheter was considered to be good for monitoring the input-output chart requirement. But now we know that CVP does not give us the correct value of how much of fluid to be given. We have to do a point of care test with the IVC collapsibility or the IVC fullness to decide how much of fluid the patient has to get, not based on CVP values. But we put CVP because CVP you can give, let's say you want to give potassium or you want to give a lot more blood and blood products, then central venous line is important. Arterial cannulation, mostly we do on the radial artery. And arterial cannulation is important when you have either a severe hypertension or a hypertension. So basically when the critical mother comes, we go through various parameters all across and then we come to a conclusion and we manage the patient. Now mechanical ventilation is again very important. We need to know a few aspects of mechanical aspiration, not 2 points. I'm not asking you because you're not going to do a mechanical, even I don't do a mechanical ventilation. My intensivist does the mechanical ventilation, but you should know that certain things like, your intensivist has not done obstetrics. Your intensivist has not studied maternal physiology. Who has studied maternal physiology? You. So you should be able to guide everybody as to what has to be done. The PEEP has to be increased in most of our pregnant patients, and you keep a higher PEEP, they'll do better. Fluids again are a very important aspect. That is what I was talking about, the point of care test, where you can see that the whole IVC, this is the IVC. The whole IVC is like a taut and like a pipe. So this patient does not require more fluids. If I give her more fluids, she is likely to go in for pulmonary edema. Pumps and syringes, I don't know how many of you are using the pumps, all kinds of pumps and syringe pumps. Good. If you have, it's not very expensive now. Please use them if you have them, especially to give things like magnesium sulfate. If not any of the higher drugs, at least magnesium sulfate, it's better to give by syringe pump and infusion pump. Vasoactive drugs, vasopressors are where you squeeze the system, and inotropes are the drugs where you pump the system. So these, both the categories you use based on a particular individual patient. Of course, when the patient is in critical care, you have to be sure about the pneumatic compressors, the nutrition, and plan when you are going to do the surgery. A surgery should not come in too late or too early. And when we do immediate resuscitation, we follow the CAB protocol, not the ABC protocol. Olden days we were following the ABC protocol. Now the protocol has to be CAB because ultimately the compression and circulation are the most important aspect in our patients. If you are doing critical care, resuscitative hysterotomy is one of the surgeries that you may have to do. Olden days we used to call it post-mortem cesarean section, then we call it perimortem cesarean section. We don't use any of those terms now. The term now is resuscitative hysterotomy. And you just do it wherever the patient is, give one cut, get the baby out, stabilize her and then close her. And most important thing is that before we were told that we have to do in 4 to 5 minutes. It has now been found that even if you do a surgery as late as 25 minutes after a cardiac arrest, 50% chance that you will get an undamaged baby. Okay, there is a case going on in Bangalore because the mother died and they didn't get the baby out. So finally the High Court gave the party 1.5 crores. But for the patient's husband, it was not sufficient. So he has gone to Supreme Court asking for even more money. Because they said, okay, my mother died, okay, something happened to her, fine, we understand that. Why a resuscitative hysterectomy was not done? Okay. Now, critical care documentation and records are very important. Record every drug that you have given, record every counseling that you have done. I do a video counseling, I do a written counseling, my patient's own handwriting. I take a written consent if my resident would have written, plus we have a printed consent. I hope you are aware that a printed consent doesn't hold valid in the court. You cannot have a blanket consent that I may die, this may happen, my baby will die, all those kinds of things. If it's printed and kept, it has no value. It has to be written. And ethical dilemmas are very common. So many times you can see 26 weeker. Now 26 weeker, if I get the baby out, it may survive, it may not survive. But I could definitely give a chance to survive. And the mother is so sick that if I do a surgery, I may be pushing her to death. So that kind of conflict always keeps coming. Mother, baby, what do I do? Then you have the ethical dilemmas in the form of finances. There are patients who cannot afford money. What do you do for them? Of course, what I made a policy is I go around with a begging bowl, trying to get money from some philanthropic people. And but you know that dilemma is very real. And finally, the emotional well-being and communications are very important. Even when the patient survives and comes out, she gets what is called as the ICU psychosis, which is reasonably common. 30 to 40% of the patients get ICU psychosis. So you need to support her very well. Training and drills are very important. If you don't do training, you'll be like a soccer, everybody falling over everyone else. But if you train your people, it'll be like a symphony, each one playing after another. So in conclusion, remember that critical illness can complicate any pregnancy. Early warning pregnancy scores, especially MUO, can predict clinical deterioration. Don't ever forget the changes in physiology induced by pregnancy and its impact on the management. Underestimating the severity of the disease is quite common. Okay, HELLP syndrome can't come to me. Acute fatty necrosis liver will not come to me. It can go only to someone else. That's the feeling we have. Community education is very important to prevent late presentation. Each one of us can do whatever little we can so that this woman has had a problem, at least the other women in the neighborhood are safe. Differentiate between obstetric and medical disorders with hypertension. Don't miss out on them. Identify various organ dysfunction and support the failing organ system. Assess maternal and fetal risk continuously. Choose the time and mode of delivery. But remember, the best hope for fetal survival is maternal survival. So first save the mother, then save the fetus. And optimize the organ functions to ensure safe delivery. Unstable patient, no point in doing a surgery. Stabilizer. Stabilize her as quickly as you can. So no effort should be spared in the management of critically ill obstetric patients because their outcomes are often dramatically better than expected from initial severity of illness. Previous day, you would have told the relative your patient is dying. Next day morning, the patient is sitting and asking for food. That is what obstetric critical care is. And always remember that you are braver than you believe, smarter than you seem, and stronger than you think. Okay, so don't ever forget this particular. And it is in your hands. This baby versus this baby. It's totally with you as to on which side the baby is going to be. It's going to come out smiling or it's going to come and cry because he has lost his mother. So thank you all very much for a patient hearing. And you need a very good eye to catch all this. This picture is taken by my daughter and the eye belongs to my daughter. So she has made that picture and I invariably use it for critical care because you need to make sure that you see. And you only see what your mind knows. So let your mind know and then you see. Thank you very much.
Thank you, Dr. Prakash. It was really a nice presentation where you very simply, by some of the cases, you enumerated all the things which is actually required because obstetrics is really an unexpected kind of a situation. all the cases which come up as a low risk cases, they suddenly turn up into some other way. पहले ज़माने में कहते थे delivery जो है वो नया जन्म होता है, तो it is absolutely right even till today. We just have to follow the patient seriously, keep an eye, focus on the investigations, keep the things ready with us. Yes, this having an HDU kind of a setup or some of the equipments which can help us out is a really must for everyone.
Dr. Pushpa Banerjee Oration is being awarded to Dr. Prakash Mehta on the occasion of the annual function of Gorakhpur Obs and Gynecological Society on 17th November 2024 at Hotel Ramada. Congratulations.